This is a practical aid to read chest X-ray presented by me, Dr. Rasha Nadim Ahmed, radiologist at Department of Surgery in the College of Medicine. The aims of this lecture is to learn what's the chest X-ray and how to read. The chest X-ray is a type of the X-ray that's commonly used to detect the abnormality in the lungs. However, the chest X-ray can also detect some abnormality in the heart, aorta, bones, and the thoracic area. And the chest X-ray will show different densities on black, white, and the gray gradients between them. The air will be black, the bones and metals will appear white, fat and soft tissues will appear. Positioning. To take the chest X-ray, we have to put the patient in certain position. We have some standard positions. The most important one is the PA position, and especially the PA erect chest X-ray. Lateral position is sometimes requested, and we have right lateral and left lateral position. The PA chest X-ray is named so because the X-ray will penetrate the patients from posterior to anterior, and the AP positions, the X-ray will penetrate the patients from anterior to posterior to lay down. These are some differences between the PA and the AP chest X-ray. In the PA chest X-ray, we are asking the patient to elevate his shoulder up in order to make the scapula away from the body and thereby making the lung appear more clear. That's why the clavicles will appear V-shaped or downward medially directed. While in the AP film, the shoulders will be and the upper limbs the shoulders will be down and the upper limbs will be by the size of the body, and that's why the clavicle will appear horizontal. Which one is the better? Of course, the PA chest X-ray is better. The lung will appear more clear, and the heart and the mediastinum will appear more. Lateral chest X-ray named right or left according to the side which is nearest to the thumb. This is the lateral decubital chest X-ray. It has very dedicated indications. For example, in detections of very small amount of pleural effusions or pneumothorax which is not detected by the erect PA chest X-ray. Steps in reading chest X-ray is starting with evaluations of the technique, anatomy, and then we should have a systemic approach to the chest X-ray in order not to miss any pathology of the lung or the chest. First, we will start with the technique. Three main factors determine the technical quality of the radiograph include the penetration, inspiration, and what is the idea behind the evaluation of penetration? When we are imaging chest of the patient, we are giving a certain amount of the radiation. This amount of the radiations should be differ according to the size of the object. If we have an adult obese patient, the amount of the radiations given to him should be of larger amount than if we are imaging, for example, a neonate or an infant. To judge whether the chest X-ray is of good penetrations is through looking to the thoracic spine through the cardiac shadow. This red long arrow is pointing to horizontal translucency. This faint horizontal translucency representing the intervertebral disc space between two thoracic vertebrae. So, if the thoracic spine and the intervertebral disc space are just seen, not clearly seen, this means that the penetration is very good. If we are seeing them very clearly, this means that the film is penetrated, while if the thoracic spine and intervertebral disc space cannot seen at all through the cardiac shadow, this means that this chest X-ray is soft chest X-ray or under-penetrated. Has the patient taken a good inspiratory effort? The chest X-ray should be taken through a good inspiration, a full inspiration. This is just judged by counting the ribs through the lung. If we are counting the 8 to 10 ribs posteriorly or 5 to 7 reps anteriorly. This means that we are achieving good inspiration. The number one is in the blue is over the first rib. Number 4 is over the posterior ramus of the fourth rib, as will be number 7 and 10. The third thing is the rotations. The rotations, the patients should be well centered in the midline, not rotating to the right or the left while taking the chest x-ray. How can we judge from the chest x-ray whether the patient is rotating or was rotating while taking the x-ray? Is by looking to this oval wide structure, which is represent the spinous process of the thoracic vertebra that's located between the medial ends of the clavicle. Of course, the medial end of the clavicle here are drawn as vertical white lines, and the spinous process as an oval shape between them. And pointing to it is this green long arrow. Now, if this oval structure is equidistant from the medial ends of the clavicle, this means the patient is well centered, while here we have certain small rotations seen in this part. We have here 4 chest x-rays with certain technical problems. This may falsely give impressions of abnormal chest x-ray, while it's in fact only technical problem. You should look to the chest x-ray and determine what is the problem on the technique. First chest x-ray, number 1. If you are looking through the cardiac shadow to the thoracic vertebra, you will see it very clear that you can draw it with the pen. So this means that this chest x-ray is over-penetrated or overexposed. If you look carefully, you can see that these lungs are very black. Very black may lead you to think that these lungs are hyperinflated or have some problem like the pneumothorax or emphysema or so on. So you should check the technique first before you are thinking that these lungs are hypertranslucent. Second thing, if we have small lesions in the lung in this chest x-ray, we will not see it clearly because of these penetrations. Now the chest x-ray number 2, if we are looking through the cardiac shadow, we cannot at all see the thoracic vertebra. This means that it's a soft film or underexposed. Third film is an expiratory film. So the third film is expiratory film. If we are counting the anterior rami of the ribs, we are reaching the fourth or 4 ribs anteriorly. The fourth chest x-ray showing markedly rotated film. The anatomy. One of the systemic approach to evaluate the anatomy of the chest is the lungs, then A, B, C, D, E. A for airway, B for bones, C cardiac, and D is the diaphragm. And the lobes of the lungs, we should always remember that the right lung is composed of 3 lobes, that is separated by 2 fissures, the major fissure and the horizontal fissure, and this is represented by these different degrees of the green lines and violet, while the left lung is composed of the 2 lobes, that is separated by the major fissure only. We have no horizontal fissure into the left, so we have only 2 lobes. If we have a lesion, which is here, this rounded green lesion, and we want to locate it to certain part of the lung, we cannot say from the PHS X-ray whether this lesion is into the right middle lobe or into the right lower lobe. So we have the radiologist finds certain way to describe the position of the lesions in the lung by drawing these imaginary lines and dividing each lung into 3 zones: upper, middle, and lower zone. The upper zone is extending from the apex of the lung to the lower edge of the anterior ramus of the second rib. The middle zone is extending from this line to the line which is drawn through the lower edge of the anterior ramus of the fourth rib. The lower zone is below it. Again, if we have the same lesion and it's located here, we will say that this lesion is located into the right middle zone, without mentioning the lobe, because here we cannot determine whether this lesion is in the right middle lobe or in the right lower lobe. The airways is represented by the trachea and the main bronchi, as we can see in chest X-ray. The bones are including the clavicles, the scapula, the sternum, and the ribs. And this is the way how we can count the anterior rami and the posterior rami of the ribs. You should all know how to count the ribs. Cardiac shadow is very important to be evaluated in the chest X-ray, and once we are looking to the cardiac shadow, we should first determine whether the size of the cardiac shadow is normal or enlarged. This is achieved by what we call it cardiothoracic ratio. So what's cardiothoracic ratio? Cardiothoracic ratio is dividing the widest diameter of the cardiac shadow, here represented by the line A, over the widest diameter of the thoracic cage, here is represented by the line B. The ratio should be less than 50%, but it should be measured into the PA chest X-ray in an erect position. Is any cardiothoracic ratio enlargement means cardiomegaly? The answer is no, because as we can see in the chest X-ray number 1 and 2 and 3, the cardiothoracic ratio is enlarged due to cardiomegaly here, while in the number 4 here the cardiothoracic ratio is enlarged, but not due to the cardiomegaly, but due to pericardial effusion. The radiological features of the pericardial effusion is enlargement of cardiothoracic ratios, and the cardiac shadow will take the shape of the flask shape or globular shape heart. But still, the most important cause of the enlargement of the cardiothoracic ratio is the cardiomegaly. Talking about the cardiac shadow, sometime in the chest X-ray you can see a line that is bounding or drawing the outer boundaries of the heart, just like in this chest X-ray in the PA and the lateral view, and this white line is representing calcifications in the pericardium or pericardial calcifications, which has a list of differential diagnoses. One of most important is the constrictive pericarditis. Lastly, evaluations of the diaphragms. We should always remember that the diaphragms, we have two crosses of the diaphragm, right and the left. The right is usually higher than the left, but in minorities of peoples they may locate at the same level. The right is higher than the left by 2 centimeters or less, not more. We have angles, very important angles, like the cardiophrenic and the costophrenic angles. The cardiophrenic angles is located between the cardiac shadow and the diaphragm, while the costophrenic between the costal area and the diaphragm. In the chest X-ray number 1, we have the right costophrenic angle, which should be acute and translucent. Here it's completely obliterated. The obliterations of the costophrenic angles is usually caused by small pericardial effusions or pleural fibrosis. In the chest X-ray number 2, the cardiophrenic angles is obliterated, and we have several differential diagnoses for the obliterations, including the pericardial fat pad, pericardial cyst, Morgagini's hernia, and lymphadenopathy. Radiological signs. One of the most important signs in the radiology is the silhouette sign. What is the benefit of this sign? Is to locate the parenchymal lung lesions to a certain part of the lung. If we have an opacity in the lung which is obliterating the diaphragms, it should be located into the lower lobes. If the opacity is obliterating the cardiac borders, it's located either in the right middle lobe, if it's into the right, or into the lingula, into the left. This is the simply what do we mean by salute sign, and we have some practical applications for this. In the chest X-ray, number 1, we have an opacity that's located into the right lower lung zone. This opacity is obliterating the right cardiac borders, that we cannot see the right cardiac border clearly. So means that this opacity is located into the right middle lung lobe. While the diaphragm is seeing clearly, means that the lower lobe is not involved. In the chest X-ray number 2, we have an opacity in the left lower lung zone. However, the left cardiac border is seen clearly, means that this opacity is not located in the lingula because the cardiac border is quite clear. But at the same time, you cannot see the left dome of the diaphragm, means that this opacity obliterating the dome of the diaphragm. Any opacity obliterating the dome of the diaphragm is locating in the lower lobes. Air-bronchogram sign is another important radiological sign. Refers to phenomena of air-filled bronchi being made visible by opacification of surrounding alveoli. بمعنى أنه البرونكاي اللي بداخلها air راح تبدو على شكل branching translucency إذا كان محيط بها air filled fluid filled opacity مثل بالconsolidation، يعني منطقة بها consolidation الالفيولاي فيها full of fluid. البرونكاي اللي موجودة في هذه المنطقة إذا كانت تحتوي على الإير فراح نشوفها بشكل branching translucency. هذه العلامة تشير إلى أنه الباثولوجي هي برانكايمال، يعني في داخل اللنج، وليست مثلا بالchest wall أو مثلا بالميدياستاينم. This is first. وثانيا تؤكد على أن الباثولوجي هي air space أو alveolar، مثل ما نشوف بالconsolidation اللي راح ناخذها إن شاء الله في part 2 من هذا الموضوع. Practical aid to read chest X-ray presented by me Dr. Rasha Nadim Ahmed, lecturer at Department of Surgery, Nineveh College of Medicine, and this is part 2 of this. We will start with some radiological findings in parenchymal diseases. The parenchymal lung pathology could be either translucency or opacity. The opacity and the translucency both can be either focal or diffuse. Focal lung opacity, we have 4 differential diagnoses, and we will start with. The differential diagnoses include the patch, nodule, mass, and cavity. The patch is an ill-defined opacity of any size, while the nodule and mass are both well-defined opacities. The difference is only in the size. If the size of the nodule is less than, or of the opacity is less than 3 cm, this is nodule and it's mostly benign. If the size is more than 3 cm, this is malignant. The cavity is an air-containing opacity. The chest X-ray down in this slide showing patch in the chest X-ray number 1, nodule in the chest X-ray number 2, mass in the chest X-ray number 3, and cavity with air fluid in the chest X-ray number 4. Let's try this approach in the diagnosis of focal chest X-ray opacity. If we have a parenchymal lung pathology and it is well defined, so we are dealing with either mass or nodule, so we should look for the size of this lesion. If it is small, it's nodule. If it's large, this is a mass. Nodule have different differential diagnoses. Among most important differential diagnoses are the granuloma, hamartoma, small hydatid cyst, IV malformation, all are benign. And we have also metastasis and bronchogenic carcinoma, which are causes of malignant nodule. Some radiological features can help in differentiations of benign and malignant lung nodule. Among these, the calcification. Calcification is usually seen in benign nodule. The size. The larger the size of the nodule, the greater the risk of malignancy. The margins. We have a sign which is called as corona radiata sign, which is a speculated margin. If it is present, it's highly associated with the malignancy. Lobulated or scalloped margins are associated with the intermediate probability. Smooth margins are more likely benign and less metastatic in origin. This chest X-ray showing calcified lung nodule seen into the right upper lung zone. It's a benign nodule, and here it's due to the granuloma of the patchy opacification. Patchy opacification, as we said, it's an ill-defined opacity of any size. We have two differentiated diagnoses, collapse and consolidation. This table is showing the main difference between the two. Consolidation is an air space filling with a fluid or cells. يعني الاير اللي موجود بالالفيولاي is replaced by something. ممكن يكون exudate like the pus, or transudate like pulmonary edema, blood like hemorrhage, or protein like alveolar proteinosis, and lastly it could be cells مثل alveolar cell carcinoma. أما الكولابس هو عبارة عن loss of size of the lobe أو lobule or area due to the obstructions of the bronchus. Mainly obstructions. We have several types of collapse. Let's talk about the obstructive type. The obstructive type of the collapse is caused by obstruction of the bronchus. Since that the bronchus is a tubular structure, فالobstruction ممكن يكون من داخل اليومن مثل aspirated foreign body، أو من الwall of the lumen مثل bronchogenic carcinoma، أو من outside the wall and compressing the wall like a mass or lymph node. Let's try this approach in dealing with the focal chest X-ray opacity. If you have a parenchymal lung pathology and it is ill-defined, means you are having a patch. The next step is looking to the signs of loss of volume. Absent means consolidation. Present means collapse. The next step is localization of the lesion. If you can localize the lesion to the lobe from the PA chest X-ray, this is very good. If you cannot, you may also need lateral chest X-ray. This is an example of patchy opacification. هل ناخذ chest X-ray رقم 1. Chest X-ray number 1 showing patchy opacifications into the right upper lung zone. Ill-defined opacification. فإذا we are dealing with the patch. The second step, is there any signs of loss of volume؟ اللي هي ممكن تكون deviation of trachea أو elevation of horizontal fissure. Neither of them are present, so we are dealing with the patchy opacification without loss of volume, so we are dealing with the consolidation. سؤال, what is this sharp horizontal line which is present at the inferior border of the patchy opacification؟ الجواب هو horizontal fissure. لاحظوا أنه هذا fissure is extending from the hilum to the lateral chest wall, and this is the normal anatomical position of the horizontal fissure. It's neither elevated upward nor depressed downward. لأنه لو كان elevated معناها عندنا loss of volume. لو كان depressed معناها عندنا signs of increase of volume. إذن this is a right upper lung zone opacity. Can we localize it to the lobe? Yes, it's located into the right upper lobe. شلون عرفنا إنه هي right upper lobe؟ لأنه هي limited inferiorly by horizontal fissure. Any opacity limited inferiorly by horizontal fissure, it should be located above the horizontal fissure. لأن horizontal fissure هو اللي يفصل لنا بين الupper lobe والmiddle lobe. و vice versa, any opacity limited superiorly by the horizontal fissure, it should be located into the middle lobe. راح نشوف عليها أمثلة في الأشعاعات القادمة. فإذا نرجع للتسلسل معنا. إذا نحن عندنا patchy opacification، وهذه patchy opacification without loss of volume، فمعناها نحن عندنا consolidations، والlocation معناتها هي in the right upper lung lobe. Chest X-ray number 2 is another example of right upper lobe consolidation due to the pneumonia، ولكن هنا في pediatric age group. طبعا هذه chest X-ray showing also a patchy opacification in the right upper lung zone limited inferiorly by horizontal fissure، لكن the shape of the fissure is displaced inferiorly due to increase of the volume of the right upper lobe. And this increase of the volume is caused by a special type of the pneumonia, which is called as the Friedlander's pneumonia, caused by specific organism like Klebsiella pneumonia. These organisms are pus forming. The pus will increase the size of the lobe, and it will result in the bulging fissure sign. Another example of patchy opacifications in the right lower lung zone. إذا تلاحظون ال PHS X-ray, this patchy opacification is limited superiorly by very clear line. هذا اللاين يمتد من الهايلم إلى اللاترال chest wall، وهذا هو ال horizontal fissure. إذن we have patchy opacifications، وهاي ال patchy opacification not associated with any loss of volume، مثل ما تلاحظون أنه mediastinum is central، لأنه ال patchy opacification في هذا المكان usually causing mediastinal shift أو elevation of the diaphragm. Neither of them is present، فمعناته the patchy opacification is not associated with the loss of volume. إذن we are dealing with the consolidation. بالنسبة لموقع الكونسوليديشن هو limited superiorly by horizontal fissure، ونحن اتفقنا أي opacity limited superiorly by horizontal fissure should be located into the right middle lobe. مما يعزز كلامنا هو looking to the cell width sign. إذا تلاحظون أنه right cardiac border cannot be seen، ما نقدر نمشي عليها بالقلم، but this means that there is a loss of right cardiac border. فمعناها أنه this lesion is located into the right middle lobe، في حين أنه ال lower lobe is not affected because you can see the right dome of the diaphragm is very clear, means that the right dome of the diaphragm or the right lower lobe is not affected. بالlateral chest X-ray تلاحظون هناك triangular opacity تقع بين خطين، خط هو يمثل لنا horizontal fissure والآخر يمثل لنا oblique fissure. In the chest X-ray نلاحظ أنه ال left lung is more opaque than the right lung. أيضا نلاحظ السهم الأحمر يشير إلى tubular translucency، تمثل لنا وجود الإيروبرونكوغرام. بعد ما شخصنا أنه we have a patchy opacification، لأنه ill-defined opacity in the left lung، we should look for the signs of loss of volume. إذا تلاحظون أنه التراكي central، mediastinum is central، diaphragm left diaphragm is not elevated، so we are not having any signs of loss of volume. إذن we are dealing with the patchy opacification due to the consolidations. الخطوة التالية هو localization of the lesions. From the PHS X-ray يلاحظ أنه left cardiac border is clearly seen. إذن اللينجولا is not involved، لأنه lesions باللينجولا مفروض يعملن obliterations of the left cardiac border. أيضا تلاحظون أنه من ال PHS X-ray أنه left dome of the diaphragm is very clear، إذن lower lobe is not affected. فإذا من ال PHS X-ray this lesion is mostly in the left upper lobe. لو نجي إلى lateral chest X-ray نلاحظ أنه فعلا we have the oblique line. هذا الأوبليك لاين يمثل لنا الأوبليك fissure، و anterior to it there is an opacity representing the patch opacification in the upper lobe. In the PHS X-ray we have a patchy opacifications into the left lower lung zone. Again there are no signs of loss of volume, and this opacity not obliterating left cardiac border، إذا not affecting lingula. لكن ماذا نشوف ال left dome of the diaphragm، إذا it is located into the left lower lobe. So this is a left lower lobe consolidations mostly due to the pneumonia. لو أخذنا lateral chest X-ray نلاحظ أنه ال lower dorsal spines looks more opaque، يعني أكثر بياضة من ال upper dorsal spines، وهذا normally ما نشوفه. المفروض بالطبيعي بالlateral chest X-ray أنه ال lower dorsal spines تكون more translucent than the upper dorsal spines. whenever this sign is reversed فمعناها احنا عندنا pathology في ال lower lung lobes. In this chest X-ray we are dealing with opacity in the right upper lung zone. هذه ال opacity limited by a line which is directed upward. هذا اللاين يمثل لنا ال horizontal fissure، لكنه elevated horizontal fissure. The trachea looks central, slightly deviated to the right أو ممكن نعتبرها أيضا central. لكن we have these deviations of the fissures is upward. فمعناها عندنا lesions بالright upper lung zone that cause the upward deviations of the horizontal fissure. وبالتالي we have right upper lung collapse. لأنه نحن قلنا أنه أي opacity limited inferiorly by the horizontal fissure هي تقع في ال right upper lobe. The chest X-ray اللي هي to the left we have patchy opacifications with some aerobronchogram. patchy opacifications limited inferiorly by a line. هذا line is concave upward or elevated upward ويمثل لنا الhorizontal fissure. Again the trachea and mediastinum is central لكن الhorizontal fissure is elevated. إذا عندنا واحدة من signs of loss of volume, so we are dealing with the right upper lobe patch due to the collapse. Another examples of right upper lung zone opacity which is causing elevation of the horizontal fissure. لكن في هذا chest X-ray horizontal fissure ماخذ شكل غريب. هذا الشكل هو depressed medially and elevated superiorly or making what we call it reversed S sign أو golden S sign. الجولدن اس ساين هي ساين نشوفها لما يكون عندنا هايلر ماس تعمل depression بالهوريزونتال فيشر in its medial part. وبنفس الوقت هذه الماس سوت بريشر على البرونكس وسدت البرونكس ونتج عنها رايت upper lobe collapse. فهذا الكولابس راح يرفع الجزء اللاترال من الفشر فنشوف الفشر بهذا الشكل اللي هو reverse S sign or golden S sign which is specific for the hilar malignancy with the right upper lobe collapse. These two chest X-ray A and B both are in lateral position. Both are showing an opacity that is limited between the horizontal fissure and the oblique fissure. الفرق بيناتهم أنه بالchest X-ray A الفرق أنه في chest X-ray A opacity is taking the triangular shape because both the horizontal and oblique fissures are in their normal anatomical position. لكن opacity بالchest X-ray B ماخذة tongue like shape due to the approximations of both fissures to each other because of loss of volume فنتج عنا هذا tongue shape. إذن opacity بالفيلم A هي due to the right middle lobe consolidation while opacity B هي due to the right middle lobe collapse. في هذه الchest X-ray أكثر ما ممكن نلاحظه أوضح شيء هو الميدياستاينم. إذا تلاحظون أن الميدياستاينم الهارت is shifted totally to the left. Mediastinal shifting, how can we judge it? We can judge it by drawing a line over the transverse process in the midline, and this line should transect the cardiac shadow into 3/3. مفروض ثلث cardiac shadow يكون to the right of the midline and 2/3 to the left of the midline. لكن تلاحظون بهذا chest X-ray أنه all the mediastinum and heart shifted to the left. هذه أول ملاحظة. الملاحظة الثانية أنه behind the heart we have the left we have two lines وكأنما two cardiac borders. هاي يسموها double left cardiac borders أو يسموها retrocardiac triangular opacity. الملاحظة الثالثة أنه normally مفروض left dome of the diaphragm is lower than the right dome of the diaphragm. لكن في هذا chest X-ray left dome of the diaphragm is higher than the right dome of the diaphragm. فلو جمعنا هذه النقاط نلاحظ أنه shifting of mediastinum to the left و elevation of the left dome of the diaphragm high signs of loss of volume زائد retrocardiac triangular opacity أو left double cardiac borders. لو نجمع هذه نحصل على نتيجة واحدة وهي left lower lobe collapse. هذه مثال آخر للليفت لور لوب كولابس. تلاحظون أنه الميدياستانال شيفت هنا أقل من التشيست إكس راي السابقة، لكن تلاحظون أنه الريتروكاردياك تراينجولار أوباستي أو الليفت دبل كاردياك بوردرز كلش واضحة. وممكن إذا كنا ما متأكدين نأخذ اللاترال تشيست إكس راي. تلاحظون باللاترال تشيست إكس راي إنه اللور dorsal spines more radio opaque than the upper، وهذه abnormal وتعتبر signs of lower lobes pathology. انتهينا من الباتش والنوديول and we will start talking about it. مثل ما تكلمنا الكافيتي هو عبارة عن air containing opacity. الابروach أنه if we have a parenchymal lung lesions and it's air containing so we are dealing with the cavity. وأهم نقطتين في الكافيتي هي checking of wall thickness and بالحقيقة هذا المخطط ينطينا some differential diagnosis عن ال cavity content and how can we differentiate according to the content and according to the wall thickness. وأعتقد إن شرحت بالتفصيل في المحاضرة، فأتمنى تراجعوها بالمحاضرة لضيق الوقت. There are some examples of the cavitary lung lesions, chest X-ray number 1 and 2 and 3 showing air containing cavity with air fluid level. air fluid level هو هذا الخط اللي يفصل لنا بين الترانسلوسنسي أو السواد اللي فوق اللي يمثل إنه هو الاير، والأوباستي اللي تحت اللي تمثله الفلويد. ف chest X-ray 1 and 2 and 4 are examples of lung abscess. الصورة رقم 3 اللي هي CT scan، والسؤال why don't we see air fluid level here، بالرغم من أنه this is lung abscess. هذا سؤال تفكرون بينه وتجاوبون إن شاء الله. Another example of the cavitary lung lesions, and here we are having CT coronal section and CT axial sections. We have cavitary lung lesions وبداخل الليجنز أكو سواد اللي يمثلن الإير، وبداخل السواد أكو بياض اللي يمثلن soft tissue opacity. فإذا cavitary lung lesions with the soft tissue content, what is the probable diagnosis and what are other differential diagnoses؟ هذه أيضا سؤال. mass. The mass is well-defined opacity and it's mostly malignant. First of all, we should exclude the bronchogenic carcinoma, other differential diagnoses including the dilated cyst and metastasis. The pulmonary mass يدخلنا موضوع البرونكوجينيك كارسينوما، موضوع مهم جدا وعليه ثقل كبير جدا. We have certain pathological types of the bronchogenic carcinoma اللي هي adeno أو squamous أو small cell أو large cells. طبعا هذه التايبس is not a radiological types، هي pathological type. المهم منه أنه إذا تلاحظون أن squamous cell carcinoma و small cell carcinoma يبدأون بحرف الS، فأتمنى تتذكرون أن both of them are causing central masses، بينما الادينوكارسينوما large cell carcinoma are causing peripheral masses. يمكن استنتجت من كلامي أنه نحن نقسمها radiologically إلى central bronchogenic carcinoma and peripheral، لأن radiological features تفرق بين. لو نلاحظ هذه القائمة الطويلة من radiological features of bronchogenic carcinoma، ممكن أختصر لكم هي بهذا الشكل. The bronchogenic carcinoma can be presented with any radiological features in the chest X-ray. Could be nodule, mass, patch, cavity, focal, diffuse, pleural, effusions, diaphragmatic, chest wall, lymph nodes in the mediastinum, in the hilum, rib destructions. Whatever you think, it can present with this feature. فإذا في كل chest X-ray راح تمر علينا راح ننطي الكي features اللي توصلنا إنه هاي البرونكوجينيك كارسينوما. نبدأ بأسهل الفيتشرز of bronchogenic carcinoma اللي هي lung mass. مثل ما تلاحظون إنه this chest X-ray containing very large lung opacity اللي هي in the right upper and middle zone، واللي هي lung mass and this is mostly bronchogenic carcinoma. We should suggest the CT scan to exclude the bronchogenic carcinoma. يجب أن نتذكر دائما أنه chest X-ray modality لها محدودية، مثل ما كل فحص بالدنيا له حدود معينة. فبالchest X-ray ما نقدر نفرق بين الماس السوفت تشو وبين الفلويد. طبعا هذا المريض بعد ما عمل انفستيجيشن والى اخره رجع بعد فتره بهذه التشست اكس راي، واذا به هذه الماس تحولت الى كافيتاري لانج ليجنز with the air fluid level، لكن هذا الاير فلويد ليفل ليس ستريت وانما ويفي، الساين اللي نسميها ووتر ليلي ساين وتكلمنا عليها بالمحاضرات النظريه، واللي هي تعتبر ساين specific to hydatid cyst. فاذا this mass طلعت بعدين hydatid cyst. بالحقيقة هي مو مشكلة الراديولوجيست متى ما يشخص لانج ماس لازم يبعث المريض إلى CT سكان، وبالCT سكان ممكن يفرق لنا إذا كان هذا fluid density أو كان soft tissue density. So as a safe radiologist you should first exclude the bronchogenic carcinoma. Another chest X-ray تلاحظون أنه عندنا 3 أسهم، الأسود والأبيض والأحمر. الأسود يشير إلى ill-defined opacity، إذن we are dealing with the patchy opacification اللي هي mostly consolidation. السهم الأحمر يشير إلى small nodule السهم الأبيض يشير إلى right hilum which looks bulky and spiculated. طبعا normal hilum لازم يكون concave out border، ما ممكن يكون convex. من يكون convex مثل هذا ويكون enlargement of the hilum is unilateral و spiculated. This is a key finding in case of the central bronchogenic carcinoma. أما consolidations هي ممكن تكون secondary features in metastasis، كان ممكن يكون secondary features. in this chest X-ray الكي finding هي unilateral hilar enlargement with spiculations، يجي معها باتش، يجي معها نوديول، يجي معها ماس، يجي معها pleural effusion، diaphragmatic elevations، mediastinal lymphadenopathy، right paratracheal lymphadenopathy whatever. The presentation الكي finding هي spiculated high. Chest X-ray number 1. This is an example of what is the key features in this chest X-ray. هاي سؤالكم. chest X-ray number 2 طبعا this is not a chest X-ray, this is a CT scan coronal section. We have a nodule but this is a malignant and it's clearly malignant, and I'm asking you about the key features which make us thinking of malignant nodule in this CT scan. Another questions is the chest X-ray number 1 and chest X-ray number 2 having certain features that indicate the malignancy. طبعا يعني لو تلاحظون chest X-ray number 2 بيها lot of features، من شكل الميدياستاينم إلى الهايلم، elevations of the dome of the diaphragm إلى الباتشي opacification of the lung، لكن أكو فت ساين بالchest X-ray هي هاي اللي توجهنا نحو المالجنسي وتخلينا نعتقد إنه this is a bronchogenic carcinoma. لما نعثر على الكي فايندينجز مثل ما ذكرت أنه البرونكوجينيك كارسينوما ممكن يجي معها أي ساين أخرى وتكون سهل الدايغنوستس عليكم. نجي موضوع pancreatic tumor. Is a special type of a bronchogenic carcinoma, where it's usually seen at the apices of the lung. Here the plain film demonstrates soft tissue opacity at the apex of the lung. It may be associated with the rib involvement or extension into the supraclavicular fossa. ويفيدنا اللوردوتيك فيو في البانكوستيك تيومر. عادة مريض البانكوستيك تيومر يجي with signs of the upper limb neurological أو vascular signs نتيجة involvement of the blood vessels أو the brachial plexus، مثلا يجي به pain in the upper arm أو congestion، أو ممكن يجي بالهورنر syndrome اللي هو ptosis, semiosis and anhidrosis. All these features are not features of benign lesions but of malignant lesions، لأنه these lesions may extend to the brachial plexus, blood vessels and nerves and so on. X-ray وأعتقد إحنا شرحناها بالسلايد قوي واضح. diffuse lung opacity. بعد ما نهينا الكلام عن الفوكال lung pathology, we are now talking about the diffuse lung opacity. diffuse lung opacity موضوع كبير وموضوع معقد، ويحتاج بالإضافة إلى chest x-ray ممكن يحتاج إلى CT scan، ويحتاج إلى الاستعانة بالكلينيكال بيكتشر حتى الإنسان يصل إلى، أو الراديولوجيست يصل إلى الدايجنوسيس الصحيح. فراح ناخذ جزء بسيط من diffuse lung pathology. حتى نفهم diffuse lung pathology لازم نفهم الاناتومي of the lung. اللنج تتكون من البرونكا تريكيا وبرونكاي وتنتهي بالالفيولاي. الالفيولاي تعتبر ان الاير سبيسز، وشكل الالفيولاي مثل ما تعرفونه هي عبارة عن كرات، وهذه الكرات مشكلة بشكل عناقيد. بالإضافة إلى هذا اللنج أيضا تتكون من الكونكتيف تيشو، والكونكتيف تيشو يمشي بها البلد فيزلز والنيرفز والليمفاتيك. فإذن أي باثولوجي تحصل في الاير سبيس اللي هي الالفيولاي راح نتوقع أنه تجينا على شكل opacities بشكل راوندد أو باتشي، زين، وتأخذ مثل شكل العناقيد أو نودولار أو باتشي. بينما لو كانت الباثولوجي بالكونكتيف تيشو أو بالبلد فيزلز أو بالليمفاتيك نتوقع أن يكون شكله ريتيكولار أو متشجرة مثل شكل الكونكتيف تيشو والليمفاتيك والبلد فيزلز اللي تكون بداخلهم. أيضا البرونكيال تري بما أنه هي متشجرة ومتفرعة، فالثيكنينج في البرونكاي ومشاكل البرونكاي ممكن تجينا أيضا على شكل reticular opacity. فإذا خلينا نبدي بالديفيوز opacity اللي هي من نوع الاير سبيس. وهنا قائمة بالديفرنشيال دايجنوسيس. إذا دققنا بالديفرنشيال دايجنوسيس of the air space راح نلاحظ أنه هي نفس الديفرنشيال دايجنوسيس اللي تكلمنا عليها بالكونسوليديشنز. لا تنسون أن الكونسوليديشنز هو أيضا air space pathology. الديفرنشيال دايجنوسيس تشمل replacement of the air in the alveoli by fluid of exudate type مثل النيمونيا، أو transudate type مثل البلمونري إديما، أو البلد مثل الهيموريج، أو البروتين like alveolar proteinosis، أو cells مثل alveolar cell carcinoma. chest x-ray 1 and chest x-ray 2 show diffuse lung opacity. مع diffuse lung opacity نلاحظ enlargement of the heart. diffuse lung opacity plus enlargement of the heart, this is usually cardiogenic pulmonary edema. cardiogenic pulmonary edema could be alveolar اللي هي تكون بشكل nodular أو nodular opacity yes or patchy opacity، أو could be interstitial اللي هي بتكون بشكل reticular أو خطوط متفرعة. فإذا سواء كانت nodular أو كانت interstitial diffuse lung disease إذا معها cardiac enlargement, this is mostly pulmonary edema, cardiogenic type of pulmonary edema. pulmonary edema have several radiological features من ضمن diffuse lung opacity, enlargement of the cardiac shadow, upward diversions of the blood vessels، هذه الخطوط اللي blood vessels اللي تكون متجهة نحو الأبيسز of the lung، وممكن تكون associated also with the pleural effusions، ممكن تكون associated with the septal lines like Kerley's B and Kerley's A line اللي ذكرناها في المحاضرة. all these features are of the alveolar pulmonary edema. لو جانا هذا ستايل بالامتحان راح نكتب diffuse lung opacifications of reticular of nodular of reticular nodular مثل ما تشوفون. والخطوة الثانية ننظر إلى cardiac size. إذا كان cardiac size enlarged this is mostly cardiogenic pulmonary edema. وإذا كان cardiac normal فإذا راح أخلي differential diagnosis اللي هي pulmonary edema or bronchopneumonia. diffuse bronchopneumonia. This is another example of interstitial pulmonary edema in acutely ill patient. Another examples of the pulmonary. In this chest X-ray, we are having patchy bilateral opacifications at both lung apices والcardiac size is normal. This is mostly a bronchopneumonia rather than pulmonary edema. It's mostly pneumonia rather than edema. Number 2, distributions of this patchy opacification into the upper zone. And number 3, presence of cavitary lung lesions. If you are looking to the left upper lung zone, we have rounded translucency which is caused by the cavity. فإذا نعيد تسلسل أفكارنا. Bronchopneumonia in the upper zones with the cavitary lesions تساوي لنا post primary TB bronchopneumonia. هذه أمثلة أخرى للبوست برايمري تي بي برونكونيمونيا. تلاحظون أنه هي عبارة عن patchy opacifications. تختار الأبر زونز وعادة بها small lucency، ممكن تكون rounded، ممكن تكون oval، معناها بها cavitary tendency. this is mostly a post primary TB bronchopneumonia. We have two chest x-ray or both of them showing diffuse lung pathology. إذا تلاحظون chest x-ray اللي بالleft the patch opacifications is into the middle and into the lower zone. بينما in the chest x-ray to the right, the patch opacifications is into the upper zones and it contains lucency which is due to the cavitary lesions. فإذا both of them are bronchopneumonia، لكن البرونكونيمونيا chest x-ray اللي بالرايت واللي هو distribution مالته to the upper lobes, this is usually due to the TB, while the other one is due to the bronchopneumonia اللي هي العادية. diffuse parenchymal lung pathology. بعد ما تكلمنا عن الاير سبيس راح ناخذ فقط جزء من الانترستيشيال. interstitial diffuse parenchymal lung pathology could be reticular, reticulonodular, nodular and linear. we'll start with nodular اللي هو من أبسط الأنواع. nodular يعتمد على size of the nodule. if the nodule is very small أقل من 2 ملم نسميها ملياري. and we have micronodular, we have nodules 7 to 30 millimeters larger أو masses, multiple masses. so miliary, micronodular أو nodular or masses. for the miliary shadow we have differential diagnoses like TB and chickenpox, as well histoplasmosis as infection. we have metastasis and pneumoconiosis. other types is mostly associated with the metastasis. This is example of miliary TB. طبعا miliary shadow عادة يجيب هذه الصورة small أو tiny nodules diffusely distributed in both lungs. والديفرنشيال diagnosis مثل ما ذكرنا ممكن تكون infection مثل التي و chickenpox والهيستوبلازموسيس، ممكن تكون pneumoconiosis اللي هي occupational disease، وممكن تكون metastasis. طبعا هذا الملياري اللي موجود بهذا chest x-ray هو في طفل and this is manifested by the non-fused epiphysis. إذا تلاحظون إنه الهيومرس the epiphysis of the humerus is not fused, this is skeletally immature skeleton. فلما نخلي differential diagnosis يعني طبعا of course الميتاستاسيس والنيموكونيوسيس are unlikely in pediatric age group. فإذا we left with the infections especially the TB and the chickenpox. وبالمناسبة both the primary and the post-primary TB can present with the miliary shadow. These are other examples of the miliary shadow, but here in an adult patients. So the differential diagnosis include the infections, metastasis, and the pneumoconiosis. Examples of multiple nodular shadow or diffuse nodular shadow, and the cause is the secondary metastasis. This type of the nodules have a special name called as cannonball metastasis. Now, we have talked about the opacity, parenchymal lung opacity, and now we will talk shortly about the translucency. As we said previously, the translucency could be either focal or diffuse. Focal translucency تعرضنا له تكلمنا عن الكافيتي بأنواعه. فإذا الفوكال مثل الكافيتي والسيست والبولي والبليب والنيماتوسيل. لكن الترانسليوسنسي إذا كان diffuse have two type, either unilateral or bilateral. Unilateral we have technical causes of unilateral, مثلا rotation of the patient to one side ممكن يخلي one of the lung appear more translucent than the other. وممكن تكون extra pulmonary disorders مثل ما شرحنا في بداية المحاضرات أنه الماستكتومي mastictomized breast ممكن يخلي الابسيلاترال lung looks more translucent than the other. والحل بهذه الحالة هو النظر إلى البريست shadow و check it if it's absent in one side. But this means this apparent increase in translucency is due to the decrease of the amount of soft tissue in the chest wall due to the mastectomy. وممكن تكون translucency unilateral translucency ممكن تكون due to the disease مثل النيموثوركس may result into the unilateral translucency. Other cause of unilateral translucency هي decrease blood flow to the lung oligemia مثل ما راح نشوفها بحالة التوف. البايلاترال decrease of bilateral translucency أيضا ممكن تكون technical ممكن تكون due to the diseases وإكزامبل عليها هو الإنفيزيما و obstructive lung disease like the إذا نلاحظ في هذه chest x-ray الواضح من هذه chest x-ray أنه both lungs showing increased translucency. There is an increase in the volume in both lungs manifested by tubular shape heart and mediastinum. تشوف أنه الهارت والميدياستاينم مضغوط وشكله tubular. النقطة الثالثة والأهم هي diaphragms. لاحظوا أن shape of the diaphragm is abnormal. This is called as flat diaphragm. كل هذه signs collectively تنطينا diagnosis of the obstructive lung disease and mainly the emphysema. Thank you very much. Some miscellaneous chest pathologies. The chest X-ray number 1 and 2 showing whitening of the hemithorax. Whitening of the hemithorax means that one of the lungs are completely obliterated by homogeneous opacity. Whenever we are seeing this whitening of the hemithorax, the next thing to check is the position of the mediastinum. If the mediastinum is well centered, means that this opacity is neither causing an increase of volume nor causing decrease of volume. If the mediastinum is shifted towards the other side, the contralateral side to the opacity, this means that this opacity is causing an increase of volume. But if the mediastinum is shifting to the same side, ipsilateral side of the opacity, this means that this opacity is pulling the mediastinum and thereby there is a loss of volume in the caused by this opacity. So in the chest X-ray number 1, there is an opacity and we can see that the trachea is deviated towards the opacity as will the mediastinum. It means that this opacity is causing loss of volume. So this is a case of collapse. While in the chest X-ray 2, there is an opacification of the left lung totally and the trachea and the mediastinum is central. Means that there is no loss of volume nor increase of volume. This is an example of the lung consolidation. In this chest X-ray, there is whitening of the left hemithorax and the trachea looks deviated towards the opacity. This is a case of total lung collapse. Another important subject is the hilar enlargement. We talked about the unilateral hilar enlargement in the subject of the bronchogenic carcinoma. Here we are having bilateral hilar enlargement. We have several differential diagnoses for bilateral hilar enlargement. One of the most important differential diagnoses for bilateral hilar enlargement, especially if lobulated like this, is the enlargement of the lymph nodes. Bilateral hilar lymphadenopathy. This is seen in some conditions like lymphoma and sarcoidosis. So whenever you meet a chest X-ray with a bilateral hilar lymph node enlargement, think of lymphoma or sarcoidosis. Whether this hilar lymph node enlargement is associated with the diffuse lung disease or not, because both lymphoma and the sarcoid may be associated with the diffuse lung disease. These are other examples of the bilateral hilar lymph node enlargement. Some with diffuse lung pathology, other without diffuse lung pathology. Diseases of chest X-ray رقم 1 هي عبارة عن واحدة من differential diagnosis of whitening hemithorax. إذا لاحظتم أنه في الموضوع whitening of hemithorax ذكرنا أنه أول شيء نشيكه بعد تشخيص whitening of hemithorax هو position of the mediastinum. في هذا الchest X-ray نلاحظ أنه الميدياستاينم deviated towards the other side، فمعناها أن opacity اللي occupy right lung is causing increase in the volume, and this is seen into the massive pleural effusion مثل هذه الحالة. أما إذا كان pleural effusion بكمية أقل فراح نشوفها مثل chest X-ray رقم 2. إذا تلاحظون أنه part of the lung is still spared والinferior border of the lung making meniscus sign. فإذا نعلق عليها بقول أنه there is an homogeneous opacity obliterating right middle and lower lung zone and causing meniscus sign with the remaining tissue of the lung, and this is mostly due to the pleural effusion. والpleural effusion مثل ما كنا نعرف هو عبارة عن fluid inside the pleural cavity of whatever type، سواء كان exudate أو transudate أو blood أو chyle نسميه pleural effusion. Another examples of pleural effusions in the chest X-ray 1 we have a meniscus sign, and in chest X-ray number 2 also we have meniscus sign. في السلايدات السابقة كان النوع البلورال effusion هو ما نسميه بالفري pleural effusions، يعني pleural effusions أو pleural fluid في داخل pleural cavity which is free of any fibrosis أو loculation. في بعض الأحيان يكون هناك أكو fibrosis في داخل البلورال كافيتي تمنع الفلويد من التحرك بحرية والذهاب إلى المناطق الديبندنت. بهذه الحالة راح يكون عندنا نوع من الفيوجن نسمينه loculated pleural effusion أو loculated pleural fluid. في هذه chest X-ray الابنورماليتي الواضحة هي عبارة عن opacity based to the chest wall، نلاحظها في الرايت hemithorax. إذا نسميها pleural based opacity. Differential diagnosis of a pleural based opacity is loculated fluid مثل هذه الحالة، واللي هو سببه عادة الإمبايما أو ممكن تكون pleural mass. في نفس الchest X-ray نلاحظ أن الهوريزونتال فيشر يبدو بلون أبيض واضح، وعادة النورمال horizontal fissure is not seen in the normal chest X-ray. فإذا هذا الهوريزونتال fissure have either fluid inside واللي نسمينه fissural pleural effusion وهو النوع الثالث من pleural effusion أو fibrosis. إذا لحد الآن we have 3 types of pleural effusion: free pleural effusion, loculated pleural effusions, and lastly fissural pleural effusion اللي يصير بداخل الفيشرز. إذا نلاحظ أيضا في نفس الchest X-ray أنه right costophrenic angle is not clear. مفروض تكون acute و translucent وواضحة، فهذا يعطينا دلالة على وجود some fluid, some free fluid in the pleural cavity. إذن لو نجمع النقاط اللي شخصناها نلاحظ أنه أكو loculated pleural fluid من خلال هذه opacity اللي هي based to the chest wall, and we have fissural pleural effusion as well free pleural fluid in the pleural cavity. Another examples of pleural pathologies and how it looks into the chest X-ray. هذه chest X-ray اللي هي رقم 1. What's abnormal with this chest X-ray? إذا ندقق النظر نلاحظ أنه left upper lung zone more translucent than the right upper lung zone. بالإضافة إلى هذا يوجد white line يفصل بين high translucency which is devoid of lung marking، يعني منطقة translucent وكأنما air ما بها أي lung marking، وهناك خط أبيض يفصلها عن بقية اللنج. ممكن إذا ندقق النظر بشكل جيد راح نلاحظ أنه ال posterior ramus of the fourth rib is fractured، فإذا fractured rib with the left pneumothorax. فإذا دخلنا إلى موضوع النيموثوركس بعد ما خلصنا موضوع البلورال effusion. Here are some other examples of the pneumothorax in pediatric age group. في الحالتين هذول الأطفال لديهم chest tube لديهم endotracheal tube بالإضافة طبعا إلى chest tube اللي هو treatment. They have endotracheal tube probably they are on mechanical ventilator. واحدة من مشاكل mechanical ventilator هو النيموثوركس. Another example of the pneumothorax, right lung, all replaced by translucent. Another example of the pneumothorax, right lung, all replaced by translucency that's devoid of lung marking. Where is the right lung? The right lung is the part which is marked by this red arrow. اللنج هي collapsed ومؤشرة بهذا السهم الأحمر، فهذا نيموثوركس. طبعا this is a large pneumothorax وأيضا نسميه tension pneumothorax. Tension pneumothorax هو pneumothorax associated with the mediastinal shift to the other side. Another example of the tension pneumothorax, and again red arrow is pointing to the collapsed lung. Another example of the pneumothorax, and he is asking what would you do with this patient? The answer is that the patient requires emergency chest tube insertion. طبعا تكلمنا عن الفلويد بداخل البلورال كافيتي وسميناه بلورال effusion، وذكرنا أنه له 3 أنواع، ممكن يكون free وممكن يكون fissural وممكن يكون insisted pleural effusion. بعد ذلك تكلمنا عن وجود الاير in the pleural cavity وذكرنا انه يسمى النيموثوركس، والآن نذكر وجود الاير والفلويد together in the pleural cavity ونسميها hydropneumothorax. chest x-ray number 1 and 2 both are example of hydropneumothorax. نلاحظ في الفيلمين وجود very big air fluid level يمتد من منطقة الهايلم تقريبا إلى اللاترال chest wall، ويفصل big opacity below it اللي هي الفلويد عن translucency above it اللي هي الاير والبقايا من الاريتد lung. pediatric chest ما راح نخوض في كثير من تفاصيل pediatric chest، عندنا فقط example 1 أو 2 من pediatric chest. في chest x-ray number 1 as well in the number 2 the left hemithorax is substituted by multiple cyst-like translucency، وهذه هي ال appearance of what we call it soup bubble appearance. And here we have two differential diagnoses. Either we are having a diaphragmatic hernia and this lucency representing air inside the bowel that ascending inside the chest due to the hernia، أو السبب الثاني أنه these cysts are part of congenital cystic adenomatoid malformation اللي بها اللك تشوف يتحول إلى cyst وتكون بهذا الشكل. Another examples of the cell signs which could be bilateral or unilateral. Mediastinal pathology. موضوع الميديستاينال باثولوجي موضوع طويل راح نتناوله إن شاء الله بالمحاضرة النظرية، ولكن لا بأس أن نعطي بعض الهنتس وبعض الحالات عن الميديستاينال باثولوجي كإكزامبل. أهم شيء لما نتعامل مع mediastinal mass نسأل نفسنا هذه الأسئلة. أول شيء is it a mediastinal mass? Not for example a parenchymal lung mass or chest wall mass. Is it really a mediastinal? And we have signs that determine whether the mass is mediastinal or not, and we will discuss it in the lecture. Second questions. Is it in the anterior, middle, or posterior mediastinum? And this is important to narrow the differential diagnosis for the mass. And third, are you able to characterize the lesion by, for example, looking to the site of the trachea? The trachea is deviated. This is mostly due to the retrosternal goiter. Or by looking to the content of the lesion. Sometimes the lesions showing calcification and it's apparent in the chest X-ray. Okay, and this may lead us to diagnose a certain pathology and so on. So after determining the lesions in the mediastinum, it's better to take the lateral chest X-ray and to look to the position of the lesions. We have anterior, middle, and posterior mediastinum. This is a radiological divisions made by radiologists, not related to the anatomy. These anterior, middle, and posterior divisions are made by two lines. The first line, red line, which is anterior to the trachea and posterior to the inferior vena cava. And the blue line is imaginary line passing 1 centimeter posterior to the anterior border of the vertebral bodies. By these lines, we can roughly differentiate the mass, whether it's anterior, middle, or posterior. How can we use these differentiations? By narrowing the differential diagnosis. As you can see in this table, each part of the mediastinum has its differential diagnosis, and remember always that every part have its mass, cyst, hernia, and vascular lesions. Without going in details, because it will be discussed in the theoretical lecture, we will go to some examples. This chest X-ray, or in fact it's a scanogram part of the CT scan, showing widening of the superior mediastinum by an opacity that is causing tracheal deviations to the left, and this opacity is extending to the base of the neck. So these are features of retrosternal goiter. Chest X-ray 1 and 2 both showing widening of superior mediastinum by an opacity that is deviating the trachea to the right, and the opacity is extending to the base of the neck. Again, these are examples of retrosternal goiter. Chest X-ray 1 showing widening of the mediastinum in the PA film, and the lateral chest X-ray showing that the widening is by an anterior mediastinal mass, as shown by the opacity seen over the opacity of the cardiac shadow, so it's anterior in position. To simplify the differential diagnosis for anterior mediastinal mass, we may use this 40s. 40 هي اختصار differential diagnosis of anterior mediastinal mass, which is teratoma أو germ cell tumor, thyroid lesions مثل retrosternal goiter, thymic lesions, and finally terrible lymphoma. terrible lymphoma. It's lymphoma, just to fit it to the other T, we call it terrible lymphoma in order to memorize it. Heart and great blood vessels. Some examples of the cardiac pathology seen in the chest X-ray. Tetralogy of Fallot is one of congenital anomalies of the heart. It is called tetralogy because we have 4 lesions. Mainly we have large VSD. Secondly, we have overriding of aorta. That's the aorta is located over the interventricular septa, and it will receive the blood from both the right and the left ventricle, not as usual where it is it's receiving the blood only from the left ventricle. Third is pulmonary stenosis. All these factors will result in a great effort in the right ventricle, which will show hypertrophy because the VSD will shift the blood from the left to the right, and this will be burden on the right ventricle. And secondly, because the pulmonary artery is stenosed, so the right ventricle is pushing the blood to a closed outlet or stenosed outlet, so this will make the right ventricle hypertrophied. So all the radiological features in the chest X-ray mainly concerning about this right ventricular hypertrophy. In the chest X-ray 1 and 2 and 3, all of them, the heart enlarged. The heart is large and the left cardiac apex is abnormally rounded and elevated. طبعا هاي هي الفيتشرز of right ventricular hypertrophy. وهذا راح ينطي الهارت special shape which is called as boot shape heart. ملاحظة فقط أنه التوف may be associated with the right sided aortic arch مثل ما نلاحظ chest X-ray 1 and 2. This is not always present, but it's present in 25% of cases. ملاحظة أخرى أنه التوف is associated with the lung oligemia. لاحظوا chest X-ray رقم 3، شوفوا أنه lungs are very hypertranslucent. زين، وهذه hypertranslucency مو نتيجة emphysema أو increase air in the lung، ولكن نتيجة قلة البلاد باللنج اللي يخلي كمية الإير أو نسبة الإير للسوفت تيشو and the blood أكثر، فتبين hypertranslucent، وسببه هو طبعا pulmonary artery stenosis. فتبدو اللنج بهذا الشكل من hypertranslucency. هذه الملاحظة أذكرها لأنه في عدد من الطلاب بالامتحان ممكن يجيهم chest X-ray مثل هذا رقم 3 ويذكرون أنه this is emphysema because the lungs appear hypertranslucent, which is not. In fact, it's lung oligemia and associated with the cardiomegaly and boot-shaped heart. طبعا مثلا بالchest X-ray رقم 1 نشوف أنه there is no lung oligemia, no hypertranslucency into the lungs. إذن هي مو شرط، ممكن in complicated TOF and reversal of the shunt ممكن تحدث أمور وتتغير الوضعية، لكن هو بشكل ستاندرد أنه TOF associated with the translucency، فنحن نعتمد على presence of the cardiomegaly, boot-shaped heart، وممكن ننظر إلى right sided aorta. إذا كان معها translucency in the lung this is better. Another congenital heart disease is the transposition of the great artery. This means that the aorta, instead of taking blood from left ventricle, it will take it from the right ventricle, and the pulmonary artery will take the blood from the left ventricle. This results into the non-mixing of the blood بحيث أنه left side of the heart always containing the oxygenated blood اللي يجي عن طريق pulmonary veins، و right side of the heart containing deoxygenated blood. فإذا this condition is incompatible with life، والطفل يحتاج إلى فتحات تضمن هذا الميكسينج أو الشنط، سواء كان عنده ISD أو VSD أو patent ductus arteriosus. أما إذا ما كان عنده هذه الفتحات this is incompatible with life. The radiological features of the transposition of the great artery, as we can see in this chest X-ray, cardiomegaly, the heart taking a special shape which is called as egg on string appearance, and the superior mediastinum is narrow. Just have a look to the lungs. Here the lungs are showing diffuse opacity, but this diffuse opacity is just due to the pulmonary plethora or increasing pulmonary blood flow.